Good with this.
All right.
The camera's good at the record.
All right, we'll start. I've stepped in to just chair this meeting quickly, so I'm Andrew Perkins. I'm going to introduce our two speakers. The idea of today is to cover the broadness of what ACVD does. So we're an institution that covers everything from malignant hematology, stem cell biology, immunology, through to a lot on coagulation. And that area in particular was a strength for many years. So with no further ado, I'm going to introduce David Curtis, who's the head of the malignant hematology program, to talk to us about clonal hematopoiesis.
Thanks, Andrew. Thank you very much. So I'm going to talk about a ideas grant, which I was fortunate enough to get last year. And it's about clonal hematopoiesis. So hands up, who has clonal hematopoiesis? You should all put your hands up because everyone's got it. It's a trick question. And because, well, maybe people under the age of 40 probably don't have it, but there are quite a few people here over 40. So I'll just introduce the team. So this is called the Asprey CHIP sub-study, and it's led by myself and Zoe McQuilton. Some of the key players have been Jasmine Singh, who's a PhD student, Sean Byers, who is the bioinformatician, and Tao Lei, who's the biostatistician. So clonal hematopoiesis came to the fore in 2014. There were three major publications, two in New England Journal, one in Nature Medicine, that described the identification of mutations that were in our blood cells in these cohorts. So the cohorts were actually, they were whole genome sequencing for specific diseases, so schizophrenia, diabetes, cancer, and they were looking for germline mutations. But they happened to find that there were the presence of these mutations at low frequency, somewhere between 2%, 5%, 10% in the blood cells, which were mutations of genes which typically are seen in acute myeloid leukemia. The definition of clonal hematopoiesis that I'm going to use is where it's at least 4% of the blood cells have these mutations. So that would be a variant allele frequency of 2% in sequencing. And there is an increasing prevalence with these papers. It was described that with age, it became more frequent. And in these studies, about 10% of somebody at the age of 80 or 10% of 80-year-olds would have clonal hematopoiesis defined by that level of clone size. And what they found was that it was associated with blood cancers and cardiovascular disease and increased mortality. But it was really unclear from all those people that had it what it actually meant and who was at greatest risk. And so for that reason, they called it clonal hematopoiesis of indeterminate potential, or CHIP. So the working hypothesis for CHIP is that we are born with a large number of healthy stem cells, probably about between 10 and 100,000 stem cells. And as we age, mutations are acquired, which give them a selective advantage so that those single stem cells can start to get a proliferative or clonal advantage, such that they can grow and contribute to the blood cells, at least 4% of the blood cells. And as I mentioned, about 10% in those original studies, but probably about 40% people will develop clones of that sufficient sort of size of 2 to 10%. And the working hypothesis is that A small number of people will go on to develop cytopenias. So that'll usually be anemia or low platelet count. And often people present or are sent to hematologists without any clear cause, and it may be that clonal hematopoiesis is the underlying mechanism. And a small proportion will develop myelodysplasia, which is a hematologic malignancy, and then acute myeloid leukemia. But really, if you've got clonal hematopoiesis, the annual risk of developing acute myeloid leukemia is still only about 1%. So most people have clonal hematopoiesis, but it's relatively uncommon that they develop myeloid malignancies. It is known for some of the risk factors. So if someone is referred, someone with CHIP, we can sort of have some ideas about who would be more at risk, and that would be specific genes which are mutated, if that person has got more than one clone, or if the clone size is quite big. So a very little frequency of 20%, that's 40% of the blood cells, would give you a higher risk of developing acute myeloid leukemia. And there's some more subtle things such as red cell shape. So there's been some large population studies. So the original ones were disease focused, but there has been some large ones, and the biggest one is the UK Biobank, where there's now over 500,000 people that have had their genomes sequenced. And using that biobank, you can really study lots of the associations between CHIP and disease. And we recently have just published a systematic review, which essentially confirms what people think, is that CHIP has an increased mortality. So if you've got CHIP, you've got a higher risk of dying, and it's predominantly of cardiovascular disease or stroke or myeloid malignancy. However, starts to be a hint that there's some increased risk of lung cancer and kidney disease. So some of the problems with these very large, even though they're very large, there are some problems. One is that these are single measurement of CHIP at the entry of the biobank, and very few people who are at highest risk, so these are people over the age of 70, are in these biobanks. The technologies used to look for clonal hematopoiesis are using whole genome or whole exome sequencing, and they're relatively insensitive. So this means that you're going to tend to pick up larger clones, and therefore it may overestimate the disease risk. These biobanks are based upon, or the clinical outcomes are based upon electronic health records, and that is notorious for having errors with those collection of that data. And one of the most important things is that these are cross-sectional studies, so that very few studies actually look at 2 time points. So we actually have no idea about what the natural history is of clonal hematopoiesis. Despite that, Sloan Kettering is probably the first place that has developed or has set up a CHIP clinic. And this CHIP clinic has CHIP specialists, hematologists and cardiologists. And currently the screening is not recommended because it's still really unknown what it all means. But CHIP is increasingly detected with the use of next generation sequencing for a variety of different things. Often the reports will say presence of small clones of mutations of DNMT3A, ASXL1, TET2 are the most common ones. So their current recommendations is if they see somebody with that, they monitor them for high risk features to progression to acute myeloid leukemia, and they provide some general sorts of advice about cardiovascular risk factors. So really the central question in the field is whether CHIP is simply a biomarker of aging, so that people who tend to age more quickly are more likely to have CHIP, and also more likely to have diseases that are age-related. So it may be just a biomarker of aging, which really is not particularly useful. Alternatively, it could be that aging-related diseases can drive CHIP, because there is evidence that people with inflammatory diseases are more likely to have CHIP. But most importantly, there is some evidence which is accumulating which chip can actually contribute to the disease. And if that's true, then that's really important, because then you can start to say, okay, what are the things that are control? How is chip causing the disease? Can we target those things? And can we actually specifically target chip or prevent the growth of chip to larger clones? And so probably the only really strong evidence that chip can drive disease is in a mouse model of cardiovascular disease. So this group took a TET2 mutant mouse and generated mice which were chimeric. So they took 90% of normal bone marrow cells and 10% of TET mutant ones, transplanted them into mice to generate these chip mice. And then they did that within a cardiovascular model, and showed that the ones which were carrying the mutant TET2 chip were more likely to develop cardiovascular disease, suggesting that the TET2 mutant cells were actually contributing to the cardiovascular disease. So what are the things that we don't know about clonal hematopoiesis? So one obvious question is, should we be screening for it? And what does it mean if an individual has chip? What happens to chip over time? As I mentioned, there are no longitudinal studies of chip. And so is there a value in monitoring it? And can we actually prevent chip from growing? And then if chip does cause disease, how does it do that? And those are the sort of the critical questions in the field. So the study that I'll talk to you about comes off the ASPRI study, which is a prevention using aspirin in elderly people. So this was established about just over 12 years ago now, and it was a large study of about 20,000 people over the age of 70 who were otherwise fit, so they hadn't had major cardiovascular disease, or heart attacks or strokes, but they could have had hypertension, diabetes, etc. And they could have also had past history of cancer, but it couldn't be present, and they had to have at least a 5-year projected survival. So this group was randomized to aspirin or no aspirin or placebo, and this is the result, which was published in 2018 in the New England Journal, which essentially showed that for primary prevention in older people, aspirin is of no benefit. And in fact, in some subgroup analyses, it suggested that aspirin was actually detrimental. And the major thing that was different was that there were more deaths related to cancer in people on aspirin. So it was around about that time that led to changes in the recommendations for aspirin as primary prevention, and so that people over the age of 65 are no longer recommended to take aspirin for primary prevention. So this is around about that time is when we thought that this would be a fantastic cohort to study clonal hematopoiesis. So it had been around for about 3 years or so, and we thought we could actually utilise this study to study clonal hematopoiesis. And some of the reasons why we wanted to do it would be that we had multiple samples. So we have a baseline sample and one 3 years after aspirin or placebo, and then a later time point. But we've also got plasma, urine, and in the later samples, we'll have microbiome to actually look at the interaction between microbiome and chip. So in 2019, we developed a custom designed chip assay, which covers 19 of the most common chip genes involved. And one of the things that we had to do was to develop a multiplex system so that we could do multiple samples. So we can do one run of measuring 5,000 samples at a time. And it has a sensitivity which is sufficient to pick up what we would define as chip of 2%, so the sensitivity of 1%, and the cost is only about $50 per sample. So I think that this, as I'll show you the data for our study, is quite compelling, but it also offers the opportunity for other groups who've got large cohorts for us to measure chip, in a collaborative research project. So as I mentioned, some of the key strengths is a large cohort with healthy elderly There's very extensive phenotyping, so that people are seen every year. And there's an endpoint adjudication for cancer and for cardiovascular disease. There's serum samples, and there's the aspirin randomization. So we can specifically ask, does aspirin impact on clonal hematopoiesis? So the first question is, are there any lifestyle factors that are associated with CHIP? So this is the baseline sample that I'm going to tell you about. I'll tell you a little bit about the year 3 sample, but the baseline sample. So these are the mutations and the frequency. So that the overall frequency of CHIP in a 70+ population is about 23%. And small CHIP, which we define as a variant allele frequency of between 2 and 10%, is 17%, and large CHIP of greater than 10% VAF is at 6%. And I'll explain why we've divided them into those major groups. So there's a list of the genes involved and the numbers. And with respect to lifestyle factors, we really couldn't find anything that was obvious other than age. Can't do anything about aging. So as you get older, you're more likely to get CHIP, which we'd already knew. And also the older people are more likely to have larger clones. So that was sort of expected, but reassuring with our data. The other thing that we did notice was that people who had a past history of cancer were more likely to have CHIP and more likely to have large CHIP. So this, I guess, was known, and the people who've had past cancer often have had therapies which may select for clones which have those mutations. But in general, this doesn't seem to be related to therapy, but we need to investigate that a bit further. So as I mentioned, there's no association with a large number of lifestyle factors. So no link with smoking, alcohol, obesity, hypertension, diabetes, high cholesterol, or renal function. So what are the clinical outcomes that were associated with CHIP? So reassuringly, the first thing we did do was confirm past studies, and that you can see that people with large CHIP, so clones of greater than 10%, have a much higher mortality. So there's a 46% increased risk of death in that 6% of people over the age of 70 with large CHIP. So what's the cause of this increased mortality? And we were betting it was going to be cardiovascular disease, but we were wrong. It's predominantly cancer-related mortality. There is some increase in cardiovascular disease, but the vast majority of increased deaths are related to cancer-related mortality. And not only that, in the people that didn't die of cancer but developed new cancers, you can see that there is a 42% increased risk of people with these large CHIP clones of developing cancers. And these are not just acute myeloid leukemia, which is a very small proportion of those new cancers. It's predominantly breast, prostate, melanoma. So this was really quite a surprise. And as you can see, for having large CHIP does not increase your risk of major cardiovascular events. So I think what this tells us is that unlike some of the previous studies, which were cohort studies in disease populations such as cardiovascular disease, if you've got a healthy population, the diseases associated with CHIP are quite different in that if you're otherwise healthy, no past heart attacks or strokes, then cardiovascular disease is not a major problem in that it's predominantly increased cancer risk. So what's the natural history of CHIP? So this is one of the real strengths of the sub-study, is that we've got a sample at baseline and a sample at year 3 and at year 7. So far, we've just measured the year 3 sample. So this was after 3 years of aspirin or placebo. And this is just a plot showing the different CHIP clones that we're comparing the ones that comparing them at baseline versus at year 3. And you can see that actually CHIP doesn't really change that much. that there's not many above or below the line. To try and sort of understand what are the things which might be affecting the growth, so which individuals might be more likely to have CHIP that grows, we calculated what's called a fitness score. So how fit are these clones? And that's essentially the log transformed year 3 divided by baseline. So that if you've got a fitness score of 0, that means no change whatsoever. If you've got a fitness score of +1, that means it's doubled over a 3-year period. So this is the fitness score for all the different CHIP genes that we've measured. And as you can see, most of them are basically at 0, which is similar to what you saw in that plot, is that most things don't change. But what you can see is that there's marked variation, so that there is about just under 10% of people where the CHIP clone actually halves in size over 3 years. In contrast, there's about 15% where it doubles in size. And it doesn't seem to be related to the type of gene it is, or to the size of the clone, or to the specific mutation of that gene. So there are some mutations which are thought to be more pathogenic because they're found in acute myeloid leukemia, but they didn't seem to correlate with CHIP growth. The things that we did note, but there are only trends at the moment, is age. So people who are older are more likely to have CHIP clones that grow. Makes sense. Females are more likely to have CHIP that grows. People with high triglycerides, there was a trend towards increased growth. And surprisingly, people on aspirin tended to have a more likely to have CHIP growth. And people who had more than one CHIP clone were more likely to have growth. So I think at the moment we can't be definitive about this because the sample size is not quite big enough and the time scale is not quite long enough to see larger changes. And so we're really going to be focusing on the year 7 sample to provide that, as well as looking at assays from the serum and the microbiome to see if we can identify modifiable factors or things which will allow us to develop a risk score for an individual with clonal hematopoiesis. So I guess the big question is, what's the impact of aspirin on the clinical outcomes? And this, I think, was a major surprise. And the surprise is that people who were on aspirin were much less likely to develop cancer. And it goes against the original conclusions where people with aspirin were more likely to die of cancer. But this protective effect of aspirin on people with CHIP only is limited to non-metastatic disease. So these are people that present with new primary breast cancer, prostate cancer, melanoma, but had no impact on people presenting with metastatic disease. So it appears like aspirin has a beneficial effect in people with clonal hematopoiesis to prevent cancer at the early stages, but not at the later stages. This is a hazard ratio of the different types of cancers that we've seen. And as you can see, there is a protective effect of aspirin in non-metastatic disease, but not for metastatic disease. And this protective effect is trending towards improvement for prostate, melanoma, and breast are the main 3 cancer types. Unfortunately, the cancer types still, we don't have enough to get statistical power, but there certainly is an obvious trend. So how does this sort of correlate? So first of all, this aspirin would be the first therapy that's actually ever been shown to have an impact on CHIP associated disease. And the other is that if this correlates to the Australian population, this would mean about 3,000 less cancers annually in Australia with the targeted use of aspirin for people with large clonal hematopoiesis. The IDEAS grant that we received last year essentially is trying to dissect out that problem by evaluating the effect of CHIP on things which might be inducing cancer. And the sort of the best hypothesis is that clonal or abnormal clones or CHIP produces high levels of prostaglandins, which are known to promote cancer growth, and that aspirin is actually preventing that or blocking that prostaglandin production. So this is the sort of the final slide, which is basically how we envisage what is the potential of this, is that similar to sort of screening for bowel cancer, we could have a sort of a national CHIP screening program at the age of 70. And if we were to do that, according to our results, about 17% would have small CHIP. And in that case, what we would like to do is develop a risk score to work out whether they were at high, intermediate or low risk. And then we could provide some recommendations with respect to that. And if they have large CHIP, so that's a variant allele frequency of greater than 10%, then we are going to be proposing a disease intervention trial, and specifically to randomise people to aspirin or no aspirin, to see whether we can confirm these results from the ASPRI sub-study. So I'll leave it with that. I've already thanked the specific people, so Zoe, we've been working with for the last 5 years. I should also point out that the assay, so this, that's critical to the whole project, was actually developed by Nick Wong, who some of you may remember, and unfortunately died a couple of years ago now. So thanks, Nick, and thanks for your attention, and I'm happy to take any questions.
So, David, I'm surprised about P53. Is that a standard CHIP thing, or did you include it to get some?
Yeah, no, CHIP, P53 is the 5th most common CHIP gene, and it's usually small clones, and they don't seem to grow.
They so you don't think the occurrence of cancer has got anything to do with P53?
No. We've looked at gene-specific and DNMT3A, which is the most common. You still see that increased risk of incident cancers.
So there was a lot of data 10, 20 years ago before CHIP on aspirin and colorectal cancer from the US and Pennsylvania. Signaling pathways were worked out. Do you think those are still relevant now, or is this? That's what
in fact, surprisingly, we did not see any benefit of aspirin in colorectal cancer. Now, whether that's just because of small numbers, we've only got 200 or 300 colorectal cancers. But
some further questions on the back?
This is just measuring the general mutagenic rate of individuals as a organism?
In part, it is because there are certainly germline variants in genes which control or DNA mutation correction. So people with those variants, they're more commonly have CHIP. But that appears to occur early. So these CHIP clones are being dated to arise, for instance, DMT3A, usually it arises when you're about 20 years of age. And then it sits there, and obviously some start to grow while others don't grow. And it's really trying to understand what are the things which make it into large CHIP, which cause the important clinical outcomes. And it's probably environmental rather than an inherent, risk of aging.
Okay.
Yeah, look, there was a slight increased risk, yes. But I mean, these are all, small numbers, unfortunately. The number of lung cancers was only about 100, I think. 120 is where the prostate melanoma were in the 200 to 300. Yeah.
So you think that doesn't increase?
Probably not. Yeah.
Can I ask you a question? The solid tumour risk is interesting. You've got some hypotheses, but My question is, in the stem and progenitor cells for all these other organs, like prostate or breast or something, they're presumably undergoing some sort of rate of chip as well as you get older.
Yes.
But I don't think any of the genes, or not some of them, but most of the genes that the chip in them are they the same genes?
No.
They're different set of genes altogether.
Yes.
They're more relevant to their tissues.
Yeah. So I didn't mention that all tissues have got chip in that lung as people age develop clones, and those clones are driven by the mutations which are typically seen in lung cancer. So they're very different to these genes. Yeah.
And is that the cancer signal? It's just that there's, they're going to slowly take over in those tissues and cause that cancer rather than being an inflammatory response?
I don't think we know what the answer to that is, but it's a very similar picture that lungs, for instance, will have these clones, and most they do not develop lung cancer.
Yeah.
Thanks, I just want to ask about the intervention. I understand that this should be like multiple factors. So if there's going to be intervention, it's going to be targeted to specific ones, or it's going to be general intervention for all of this.
So I think the general idea would be that as we age, we develop inflammation. And it's probably some people that have got a stronger inflammatory phenotype, and that may be driven by specific inflammatory cytokines, so IL-6, for instance. But the other one is microbiome, which really, in animal models, you can prevent the growth of chip by targeting the microbiome. So that would be another way of targeting it, would be to look at what are the microbiomes that promote chip.
I don't think we have time for any more questions, sorry. We better just move on to the second talk. So come up and load your talk.
Oh, you've updated.
Yeah.
Wow.
No, I realised.
So,
another
this is Dr. Keragala. She's been around for a while in Rob Megtaff's lab, and Rob's been here since the day dot.
He's still here.
A doyen of the thrombosis side of the unit, and particularly fibrinolysis. So we're going to hear an updated talk on, what's new with fibrinolysis.
Right.
Where is Rob?
Yeah, that's right. Rob has been here since day dot, but today he is not. He's currently travelling back from, he's currently travelling back from Switzerland. He was there for a week, so he sends his apologies. So I've been tasked with the big job of trying to kind of really share the work that we do in our laboratory. My name's Cherry. I'm a hematologist, and I recently finished my PhD with Rob last year. And essentially, a lot of my work looked at the intercommunication between the fibrinolytic system, which is the body's innate system that regulates blood clotting and the breakdown of blood clots, with the immune system. And today I just wanted to share a part of that story with you, and in particular a drug that we use quite commonly in tranexamic in hematology, but as well as other settings, is tranexamic acid. So what is tranexamic acid? It's really quite simple. It's a lysine analog. It was developed by Dr. Okamoto in Japan, who you see in the foreground here with her husband in the background. And it was essentially, it works as an antifibrinolytic agent, helps stabilize blood clots. It was designed to help stop obstetric bleeding, which was a significant issue back then, as it is now, but tranexamic acid has helped quite significantly in that process. And it's currently listed as a WHO essential medicines list. It also is very inexpensive. It costs approximately 60 cents for a 1 gram oral dose. It comes in both intravenous and oral preparations. So how does it work? So first, if we, a very quick summary on the fibrinolytic system, which is essentially the body's system of breaking down blood clots. It involves the activation of plasminogen to its active form plasmin by plasminogen activators, tissue plasminogen activator or urokinase. And essentially you have both plasminogen and TPA have these lysine binding sites. And cross-linked fibrin clot is coated with these lysine residues. And in the formation of the blood clot, both TPA and plasminogen are incorporated in the clot. They bring this interaction together and kind of further enhances this process of plasmin generation on the clot surface for effective clot lysis. Where does tranexamic acid work? So essentially it inhibits this interaction and stabilizes the fibrin clot and reduces its breakdown. So tranexamic acid has already been found to be very effective in different clinical settings, and this is a fantastic summary by Zoe, who's mentioned earlier as well, and also my co-supervisor. It's been found to be very effective in traumatic hemorrhage, postpartum hemorrhage, traumatic brain injury as well as cardiac and orthopedic surgery. The areas of ICH or intracerebral hemorrhage and gastrointestinal bleeding still need further investigation. The main side effect we worry about, generally thromboembolic complications, although overall the signal is very low, and seizures. At high doses, this is something that you can see. So and this is, I guess, the center of a lot of the research that I've been doing. The fibrinolytic system, even though we refer to it as that, is not fibrin-centric. So it's not all just about breaking down fibrin clots. In fact, there are many, many non-hemostatic properties of the plasminogen activating system. And a lot of these are mediated by plasminogen cell surface receptor binding. So the plasminogen activating system is involved in immunity, inflammation, wound healing, tissue repair, bone healing and remodeling in the central nervous system. It has skin effects and also may have some angiogenesis and tumor effects as well. What about plasminogen receptors? So these are actually found on all immune cells, endothelial cells, as well as platelets. There's about 1 million plasminogen binding sites per cell and about 60% occupancy at any given time. So most cells are therefore coated with plasminogen. And most of this binding is lysine dependent. So at the moment, there's about 12, 13 distinct plasminogen receptors on different cells. And most of these receptors have a C-terminal lysine residue that engages the lysine binding sites on plasminogen. So therefore, this may be a site where tranexamic acid can interact. So essentially, we could think of it as trauma or an inflammatory insult, upregulating these inflammatory cytokines, but also upregulating plasminogen and plasminogen receptors on cells. This leads to the downstream effects of multiple inflammatory events, as well as both hemostatic and non-hemostatic results. And essentially, tranexamic acid has the ability to kind of interact or inhibit this interaction and possibly augment these downstream effects. So I was going to kind of spend some time covering different areas where we've been looking at tranexamic acid, where in terms of its immune and inflammatory modulation in different clinical settings. So firstly, thought I'd start with cardiac surgery because there's been almost more than a decade of evidence in this area. In this particular study, tranexamic acid has been found to be quite an independent predictive variable with lower inflammatory cytokine levels, as well as an indication for less shock in these patients as well. There also seems to be a dose-dependent effect with higher doses resulting in more of an immunomodulatory outcome. And some studies have actually even suggested that there may be gene expression changes in the setting of tranexamic acid use. So our laboratory was very lucky to kind of be involved in a project that looked at this further, and this work was done by one of my predecessors, Dominic, who was a PhD student in our laboratory. And essentially what he did was he coordinated a sub-study of a large Atticus trial, which is run through our anaesthetics department, which looked at aspirin and tranexamic acid for people undergoing cardiac surgery. And he characterised the changes in the cytokines and circulating cellular immune profile in a subset of these cardiac surgery patients before their surgery and then in post-operative days subsequently. He also recruited 10 healthy volunteers, also known as medical students, to receive a gram of tranexamic acid, and then also looked at their immune profiling as well, just to see, guess what happens in a normal person. Quite fascinatingly, if we look at just the healthy volunteers, out to kind of 2, 4, 24 hours, there seemed to be a signal for a reduction in certain inflammatory cytokines, so interferon gamma, IL-6, TNF-alpha, IL-10. And in the actual patients themselves, what he found was that tranexamic acid increased the expression of CD83, but also decreased the expression of PD-L1. So it was almost as if you kind of surmised that there was this upregulation of CD83, these antigen-presenting cells, that enhanced immune function and almost primed the immune system. And this seemed to be driven by tranexamic acid. But what does this mean clinically? Did we see any clinical results in these patients? Quite interestingly, those patients that were received tranexamic acid in that subgroup had reduced surgical site infections. And this was despite prophylactic antibiotics being given to all patients, all comers, and it was independent of transfusion requirements. So it didn't matter if these patients were bleeding more or not bleeding as much. There seemed to be a signal for reduced surgical site infections. Now, if we went into the non-diabetic patients, this effect was even more profound. So these patients had an even better result in terms of reducing surgical site infections. And in fact, overall healthcare associated infections were reduced in those who are non-diabetic. It's interesting in terms of the non-diabetics because there is literature to say that in diabetes, there is the post-translational glycation of plasminogen that makes it less effective. So perhaps the fact that the plasminogen activating system is not working so well in those patients might have bearing on this result. So this is quite interesting. Now I'll move to burns, wounds, and wound healing. What do we know about tranexamic acid effects here? So this is a really interesting study by Tornu and his team, which found that plasminogen as a pro-inflammatory mediator was really important in the development of radiation-induced dermatitis. In fact, plasminogen null mice, as you can see here, were mostly resistant to radiodermatitis. But inhibition of this with tranexamic acid further reduced the effects of radiodermatitis in wild-type mice and those who are plasminogen heterozygous. And they surmised that it was tranexamic acid preventing this inflammatory burst that resulted in this protective effect. Other studies have also suggested that tranexamic acid suppresses the release of mitochondrial damps and that reduces lung inflammation in burns models, as well as impeding or reducing prostaglandin E2 that's released with repeated UVA exposure of fibroblasts. And this particular group suggested that there was even an anti-skin aging effect of tranexamic acid. So that was really interesting for me. So I thought, okay, well, if you just go on Google, you could actually buy tranexamic acid serum for a whopping $54, which I think is pretty exorbitant if I could get it for 60 cents. And it's actually quite a huge industry, particularly in Asia, where tranexamic acid topical therapy, but also systemic therapy is used quite extensively for skin post-inflammatory hyperpigmentation and melasma type conditions. So I think it's important to understand that these are all communicating. So we've got fibrinolysis, we've got coagulation, and we've got in the innate immune system and particularly complement systems, which are all serum protease pathways. And these are all communicating and working together. They were never meant to be in isolation. So rather than thinking of each of these systems as individual pathways, it's important to appreciate that they have multiple cross-linking, intercommunication mechanisms, and therefore tranexamic acid can work in multiple sites, resulting in different outcomes. So particularly looking at infection and inflammation, there have been some advantages that have been reported in the literature. This one goes back to as far back as 1978, where pre-incubation of normal white cells with tranexamic acid reduced their migration inhibition response. They were able to, move more. A lot of the there are many people studying the complement-mediated effects, which are that seem to be plasmin dependent. And others have again suggested that this, potentially goes down to downregulation of potential inflammatory genes as well. However, there are some disadvantages. So here, in this particular study, healthy volunteers were given tranexamic acid and then or placebo, and then challenged with a bolus of LPS. And although they found that the hemostatic outputs were significantly reduced, it didn't really impact on markers of inflammation, granulocytosis, neutrophil activation, and so forth. So this one didn't seem to show an advantage. And others have also reported on tranexamic acid being potentially aggravating staph sepsis and producing direct toxicity to human periarticular tissues as well. So there seems to be two sides to the coin. I don't think it's straight kind of simple, and that's something that we're still discovering. One study that I wanted to spend a little bit of time on that's quite kind of close to our clinical practice was in tranexamic acid use in patients with hematological malignancies, because these patients become very thrombocytopenic. And this group, who were part of the ATREAT, so the American trial to evaluate tranexamic acid in thrombocytopenia, they did a post hoc analysis of their larger study. These are hematology oncology patients who were randomized to either tranexamic acid or placebo during their period of severe thrombocytopenia. And they found that although these patients didn't have an overall difference in the rate of infections, they did have what they defined specifically as severe infections. Those with tranexamic acid seem to have less severe infections, which is really intriguing. The TXA-treated group didn't seem to have any effects on the other inflammatory outcomes, and the authors kind of concluded that further investigation is needed on this front. And that's really kind of exciting for me, because I did the sub-study for the UK and the Australian arm of this, and I'm still waiting on unblinding, so I'm really excited to see whether we see a similar effect in terms of infection rates as well. Trauma and inflammation. Tranexamic acid is quite extensively used in trauma. There's been kind of, but it remains quite controversial. Clear benefit has been shown in early use of tranexamic acid with the CRASH-2 and CRASH-3 trials. However, so far, when we've extended that to give tranexamic acid pre-hospital, try and get it in as early as possible, so far there doesn't seem to have been a significant improvement in 6-month outcomes. So this, again, seems to be this varied outcome. And I think it's important to understand that there's both kind of fibrin or plasmin dependent as well as independent mechanisms that are involved when it comes to trauma, traumatic brain injury, and inflammation. And all of these pathways clearly coexist at once. So you're getting really this kind of combination of effects. Some studies here, as you can see, have shown that tranexamic acid is beneficial. It reduces the inflammatory modulation and and seems to be dose dependent. And here there seems to be, again, a dose dependent effect with effects on leukocyte mobilization that is potentially helping with blood-brain barrier, keeping blood-brain barrier integrity in place. So if we look at it as in terms of what's happening in trauma, we're getting an upregulation of endogenous tissue plasminogen activator, this upregulation of fibrin, misfolded proteins, immune cells with these lysine residues, which provides this perfect kind of surface for plasmin generation that can then have these deleterious effects in trauma and traumatic brain injury. So again, tranexamic acid may have a role, both not in controlling bleeding, but also potentially affecting these other complications as well. And finally, aging. So this group, Hiramoto and his group, have done quite a bit of work looking at tranexamic acid in mouse models of aging with some really interesting results. So in these patients, these mice, they were given tranexamic acid until they died. And these mice showed that they actually had an increase in lifespan compared to their water drinking counterparts, as well as reductions in inflammatory cytokines and less wounds and abnormal skin growth as well. Along with that, memory and learning abilities in these mice also appeared to be much better. And again, reductions in these inflammatory processes. So I know it's been a lot, but that's just a part of, I guess, what we know so far in terms of tranexamic acid's non-hemostatic properties, particularly looking at inflammation and immunity in different clinical settings. But it doesn't stop there. There's still many kind of currently active and ongoing future studies looking at the role of tranexamic acid in immune modulation and inflammation that's completely unrelated to its hemostatic properties. And the idea of repurposing an existing, safe, well-known and affordable medication is a really attractive attractive option. And we're involved with some of these studies. This recently just came out where they're using perioperative tranexamic acid prior to patients undergoing melanoma resection, and their primary outcome is disease relapse. So they're looking at tumour relapse. So that'll be quite interesting to see. So along with the anaesthetics department, we are part of the TRIGS trial, which is looking at tranexamic acid and the reduction in infection after gastrointestinal surgery. And again, the primary outcome is surgical site infections. And that's really stemmed from that cardiac surgery study that we did. So we're part of that sub-study. Along with that, we're looking at tranexamic acid in reducing delirium postoperatively in this group as well, again, with that neuroinflammation pathway. Dominic has also done the immune sub-study looking at the immune profiling of pre-hospital tranexamic acid in the trauma patients. So that'll be interesting to see. And Dr. Zikao Liu, who's in the audience as well, did a fantastic, kind of really neat study looking at tranexamic acid in a mouse model of cerebral amyloid angiopathy, looking to see whether tranexamic acid could be a novel potential treatment for hemorrhagic stroke in these patients. So in summary, tranexamic acid has varied effects on immune and inflammatory responses in different clinical settings. And I think this is likely related to the lysine-dependent plasminogen and plasminogen receptor interactions on many different cells. But I think some really important questions still remain. One is, what's the right dose? What's the optimal dose to use? And it might vary if we're trying to achieve bleeding control versus altering immunity or the inflammatory response. And it's likely to be different in different clinical contexts. And of course, what's the optimal timing? Do we give it before surgery? Do we give it with surgery? Do we give it after surgery? And it's different in clinical situations, and the outcome may also be different. And the aim is ultimately to customize treatment so that we can maximize both hemostatic and immune modulatory outcomes as well. So with that, I'd like to thank our team and Rob, who's not here, and all our other collaborators as well. So thank you very much.
Thanks, Kathy. Great talk. Maybe there's a link between the two talks.
Yeah.
Can I ask the first question?
You can.
Should you give tranexamic acid versus placebo in people with CHIP?
Yeah, well, look, I was actually thinking of that in the last bit of David's trial, and because, well, I wonder, because I think there's no contraindication, and I only touched on the inflammatory immune pathways, but there's a lot of literature on tranexamic acid having anti-tumor effects and its role in kind of that angiogenesis and so forth. So I guess the benefits compared to aspirin is that there's no bleeding, and at the moment there's no signal for increased thrombosis either. So absolutely, why not? Yes, Harshal.
So you are attributing, it's got so many effects.
Yes.
Is it all because of plasminogen activation? Or is it something really completely different system? Because you're focused it from the plasminogen viewpoint.
Yeah.
And the data, I'm just trying to remember Rob's work on the TPA knockout mice, the TPA transgenic or the plasminogen knockout mice. They don't actually reflect everything that happened in human trials. So is it something else that is, the lysine residues, the blocking lysine residues stops from happening?
Yeah, and I think, like I said, I think there is both plasmin mediated effects, and then there's other independent effects as well. And in terms of trying to delineate exactly what's going on, I think that's still under investigation. In terms of being a lysine analog and inhibiting that plasminogen and plasminogen receptor interaction, I think that does have a significant role to play, but I definitely think there's other pathways involved. I mean, for example, some of the work that Rob has done with TPA and neurological effects, particularly after stroke, there's plasmin dependent and independent pathways involved there as well, like the PDGFCR pathway and the LDL pathway as well. So I think there's definitely other mechanisms involved.
Yeah, you can.
So the interventions that you gave with tranexamic acid, were they oral tablets or were they with the skin infections or the skin changes, or were they intravenous?
So the studies I showed combinations of either oral or IV. For example, the ATREAT trial, the hematology oncology patients, they could either have combination oral or intravenously, depending on, obviously with the surgery patients, they started off intravenously, but they could go to oral. So it's combination. And based on the studies we've done on the healthy individual medical students who got tranexamic acid, the oral bioavailability and the effects kind of from a clot lysis point of view are quite quick, quite effective, quite similar to intravenous.
So the reason I ask is I had a number of women with scleroderma and menorrhagia, and I gave them tranexamic acid about 15 years ago.
Yeah.
And they came back and they refused to give it up because their skin had completely improved.
Yeah.
And I didn't believe it. So I got the prescriptions out and looked at the ingredients, and one of them was silica. Because oral tranexamic acid is cut with a lot of silica, 90% is silica.
All right.
So they asked them to stop tranexamic acid, give them a washout period. They had the bleeding back, their skin became worse. Then I went to a pharmacy and purchased German colloidal silica with no tranexamic acid and gave it to them. The skin improved, their menorrhagia still persisted. Then I went up and looked some Google search, and many of these skin remedies actually have silica.
Oh,
so I'm just like, that was my question. Did you give oral tranexamic acid with cut with silica?
Yeah.
Or did you see the same effect with intravenous tranexamic acid?
That's really interesting. I didn't know that.
Yeah, I'm just curious with the post-surgery infections. What do you think is happening there?
In terms of the cardiac surgery patients, whoever.
After surgery, you said there was less infections. What
Well, so I don't think we completely know yet. But what what's fascinating is that, particularly in the cardiac surgery setting, it was completely independent of transfusion requirements. So the initial hypothesis was maybe these patients are sicker, maybe they're getting more transfusion. And we know transfusion can be linked to infection, but it wasn't the case, and that it was independent. So my thought is that it's part of the immune modulation. It's part of that kind of perhaps the skin and the wound healing processes that are being impacted. But I think it's really hard to kind of hone in exactly what's going on.
You think it's allowing ourselves to get to the site of where they need to work better because we're
Yeah.
not blocking it by this.
Yeah, and exactly, leukocyte migration, fibroblast growth, all of those things. Yeah, so there's quite a bit of work on burns models, and in fact we're working with the burns unit to see, because they use tranexamic acid routinely in their quite severe burns patients, to see whether we could look at other parameters and immune parameters in those settings as well. Yeah.
Can I ask a mechanistic question? So epigenetics is all the rage.
Right.
And
Yes.
in epigenetics, a lot of what's going on is driven by lysine methyltransferases, adding lysine groups to histone and tails. Is there any chance? Has anyone looked at whether tranexamic acid could be a decoy to
Alter those. Yeah.
lysine methyltransferases?
I think that's really interesting. I'm not aware.
Has anyone done stuff?
I'm not aware. I'll have to go back and have a look. But that's a really interesting comment. Yeah.
Kind of want to ask a question to the 2%. I'll compare aspirin and the TXA. Rather, aspirin in approved for long-term use. All people can take it for a very long time, and so that trial. I don't think TXA has been tested for long-term use, and especially TXA is large enough if you take something daily or something with a high dose, it can really increase rising which can cause a little bit concern, right? So comparing to aspirin, I mean, we couldn't expect like aspirin would cause something higher risk or whatever in the other people, but in terms of that long-term trial with TXA, would it be like expect something similar, or because of like this intervention rising and bring more sense? I mean, it's different from this from hormonic characteristics. Actually, metabolic characteristics. So I want to comment about this long-term trial.
Well, I mean, we really don't have any hard data looking at long-term tranexamic acid treatment in people. I think the TREAT study is probably one study that treated patients out to a month, and that's one of the longest I've kind of seen.
It's from study patients on. I mean, I've had patients on for 3 decades on tranexamic acid. People with isolated chain 9 mutations or something.
Oh yeah, for the primary bleeding disorders and things. Yeah.
And it's not enough to know a signal. It seems safe.
Yeah. No, patients with hemorrhagic or HHT, for example, who just kind of it really helps. So, I mean, anecdotally and clinically, I haven't come across any issues, and these patients don't seem to have a thrombosis signal. But looking at what other things are happening in their immune function and so forth, that's something that's
okay. It's time. I'm sorry, Aaron. These have been 2 great talks, I think, and quite complimentary in the end. So you never know what you're going to get, but we've got something great over here. So let's thank the 2 speakers, and there may be lunch, there may not be.
Oh, thanks, Harshal. That's really interesting.